This is part 2 of my lectures on the integumentary system. In the last video, we learned that the skin is the largest organ of the human body and that it has 6 major functions. Chief among these is protection. The skin is made up of keratinized squamous epithelial cells arranged in layers that form a barrier that separates the internal environments of our bodies from our external environments. This video explores the cells that make up those layers, the characteristics of the layers, and explains the sources of pigment in the skin and their significance. By the end of this lecture, you should be able to describe the cells and layers of the epidermis. This goes beyond just naming the cells and the layers. You need to also be able to talk about what the significance of the cells are, and if there are any important things that happen in the different layers of the epidermis, you should be able to talk about those as well. Next, you should be able to describe the organization of the dermis. This includes descriptions of the tissues that we find there, or other structures like blood vessels or nerve endings. As part of your description of the dermis, you should be able to describe how the papillary layer, the dermal papillae, the friction ridges, and fingerprints are all related to each other. You should be able to describe the importance of cleavage lines in the skin, and describe factors that contribute to skin color and how changes in skin color may be clinical signs of disease. In my last video, we learned that the skin is composed of 2 layers, the epidermis and the dermis. We said that the epidermis is a keratinized, stratified squamous epithelium. The main cell type in this layer is the keratinocyte. These are cells that produce keratin, a fibrous protein that helps make these cells less penetrable and gives them some strength. Other cells that we will find in this layer include melanocytes. These are spidery looking cells that produce a pigment called melanin. Epidermal dendritic cells or Langerhans cells. These are macrophages that help activate the immune system to defend the body from microbes that would enter through the skin. And at the border between the epidermis and dermis, we have tactile, or they're also called Merkel cells. These are touch receptors. This is an image of the skin made using a fluorescing microscope. As I've mentioned already, keratinocytes are the most common cells in the epidermis. Here you can see 2 examples of this type of cell. I'll highlight them in purple for you. Here's one cell. And here's the other. These cells are outlined in green. The red strands that you see are the keratin fibers that have been labeled with a red dye. As you can see, the keratin forms a network in the cell cytoplasm. When they are first made in the deepest layers of the epidermis, keratinocytes are living cells and contain only a little keratin. As these cells migrate towards the surface of the skin, however, the keratin fibers get longer and thicker, gradually filling the cell with protein as its nucleus and organelles gradually degrade. Once a keratinocyte reaches the surface of the skin, it is a dead cell, not much more than a protein-filled membranous sac. The green dots that you see, like these right here, are the desmosomes. Remember, desmosomes are cell junctions that spot weld cells together and give a tissue some resistance to mechanical damage. As you can see in this image, there are desmosomes located all around the periphery of the cell. These are melanocytes. Melanocytes are the second most common cell in the epidermis. These cells, as you can see in this image here, are located in the deepest layer of the epidermis, where they produce melanin, and the orangish-brown pigment that absorbs UV light, like light from the sun. You'll notice in this image the melanin granules, the brown, dusty-looking material, It appears to be clustered around the nuclei of these keratinocytes. Melanin helps to protect the DNA in the nuclei from damage by the UV light. In this bottom image, you'll see melanocytes, but this image is from a fluorescing microscope. Here, we can see that melanin is bundled into granules called melanosomes, and they've been stained green. Melanosomes are moved along the cytoskeleton of the cell to these processes reaching out from the melanocyte. There, at the end of the process, the melanosomes are taken up by nearby keratinocytes. Now, let's look at how keratinocytes, and to a lesser extent the melanocytes, are organized in the epidermis. The epidermis is composed of 5 layers. From deep to superficial, these are the stratum basale, the stratum spinosum, the stratum granulosum, the stratum lucidum, and the stratum corneum. You will need to remember the layers of the epidermis in order, either from deep to superficial or from superficial to deep. This is a mnemonic device to help you remember the layers in order. The first letter of each word corresponds to one of the layers of the epidermis. So, brilliant, studying gives loads of confidence. The B in brilliant goes for the basale layer. The S in studying is for spinosum. The G in gives is for granulosum. The L in loads is for lucidum. And the C in confidence is for corneum. Now let's look at the cells of the deepest layer of the epidermis, the stratum basale or basal layer. The stratum basale consists of a single layer of rapidly dividing stem cells, as depicted here. These cells are tightly attached to the underlying dermis via the basement membrane that supports the epidermis. Typically, when a keratinocyte of this layer divides, one cell remains as part of the stratum basale, and then the other cell begins to migrate from the stratum basale towards the superficial layers of the epidermis, ultimately ending in the stratum corneum. As the cell makes this journey, it slowly begins a march towards death. Its organelles and nucleus disintegrate, and it fills with keratin. The next layer is the stratum spinosum, which is sometimes called the spinous layer, the prickly layer, or the prickle cell layer. The stratum spinosum is 8 to 10 cell layers thick and is sandwiched between the stratum basale and the stratum granulosum. The keratinocytes in this layer contain a web-like system of intermediate pre-keratin filaments attached to desmosomes. The cells take on a spiky appearance when they are stained with hematoxylin and eosin, 2 common laboratory stains. Also in this layer, we will find melanocytes producing lots of melanin granules, and we'll find dendritic cells. Dendritic cells are macrophages that defend deeper layers of the skin from invasion by microorganisms. Next is the stratum granulosum, or granular layer. This layer is thin, consisting of only 3 to 5 cell layers. Keratinocytes in this layer begin to flatten out and fill with keratin. At the same time, the cell's organelles disintegrate and the cell dies. In stained specimens of the skin, keratohyalin and lamellated granules, like these, stain an intense purple or red, making this layer of the epidermis easy to identify. The stratum lucidum, or clear layer, is only visible in the thick skin from the palms of your hands or the soles of your feet. It is a thin, transparent band superficial to the stratum granulosum. You can see it in this microscope image here. This layer consists of a few rows of flat, dead keratinocytes. And finally, we have the stratum corneum, which is sometimes called the horny layer. This layer consists of 20 to 30 rows of dead, flat, keratinized, membranous sacs. This is what's left over after the keratinocytes have died and they have filled with keratin protein. This layer is 3/4 of the epidermis's thickness, and it has many functions. It protects from abrasion, that's scratching, and penetration. It helps to waterproof the skin, and it serves as a barrier against biological, chemical, and physical assaults. Okay, now let's take a look at two questions that are similar to ones that appear on exam number 2. Here's the first one. A patient is taking a drug that inhibits cell division, such as certain chemotherapy drugs. Which layer of the epidermis would you expect to be affected first? Would that be the stratum corneum, the stratum lucidum, the stratum spinosum, or the stratum basale? Pause the video and join me when you think you've got the right answer. The stratum basale is the correct answer here. Remember, the stratum basale is where keratinocytes are actively dividing at a rapid pace. So this is where we would expect chemotherapy drugs to have the greatest and the fastest effect. Marjorie is receiving estrogen replacement therapy using a patch that she applies to her arm. In which order does the treatment pass through her epidermis? Would that be the stratum basale, stratum spinosum, stratum granulosum, stratum lucidum, stratum corneum, the stratum basale, stratum spinosum, stratum granulosum, stratum corneum, stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, stratum basale, or stratum corneum, stratum granulosum, stratum spinosum, stratum basale. That's right. The correct answer here is stratum corneum, stratum granulosum, stratum spinosum, stratum basale. Remember, there is no stratum lucidum in the thin skin that you would find on the arm. As the drug diffuses out of the patch into the epidermis, the first layer that would be penetrated would be the stratum corneum. So number 4 is the correct answer here. Some medications are toxic if swallowed, but safe if used topically, that is applied to the surface of the skin. For example, certain topical antibiotics like bacitracin or polymyxin B, components of Neosporin, they're fairly toxic if taken by mouth, but can be applied to the skin with minimal risk of systemic absorption. They are polar molecules that cannot pass through the epidermis to reach blood vessels in the dermis, and so that means that their effect is local only. Now, other substances, such as hormones in birth control patches, they're nonpolar substances and they cross the epidermis much more easily. This provides a convenient route of administration for those types of medications. Unfortunately, many poisons and toxins like thallium, a heavy metal, are also nonpolar, so that means that they also cross the epidermis with some ease. Therefore, it's always a good idea to wear gloves when you're handling chemicals. Now, deep to the epidermis, we have a second layer called the dermis. In this image, it's represented by all of this pink that you see right here. The dermis is a highly vascular tissue that's deep to the epidermis. Its functions are to provide a blood supply for the epidermis, to house sensory receptors, and to anchor the epidermis in place. The dermis consists mostly of strong, flexible connective tissue like areolar tissue or dense, irregular connective tissue. Cells that you find in this layer will include fibroblasts, macrophages, and occasionally mast cells and white blood cells, which are cells of the immune system. Your dermis has two main layers, the papillary layer, which is superficial, and the reticular layer, which is deep. The papillary layer makes up approximately 20% of the dermis, and it is composed of areolar connective tissue with blood and lymph vessels, as well as sensory nerve endings. Dermal papillae are structures of the dermis that poke up, like these, into the epidermis. These structures contain capillary loops that allow diffusion of oxygen and nutrients to the extracellular fluid of the dermis and epidermis. Dermal papillae also house Meissner corpuscles, as depicted here. These are light touch sensory receptors. They are numerous in the fingertips, the lips, the face, and the external genitalia. Free nerve endings like these that are associated with the papillary layer detect potentially harmful stimuli such as hot, cold, and light touch. These receptors are less sensitive to stimuli than the Meissner corpuscles. Dermal ridges are skin features, aka markings, that are found where dermal papillae are more prominent, usually due to the presence of thick collagen bundles. So as you can see here, we have a couple of dermal papillae, and they push up into the epidermis and cause this bulge here. These ridges cause indentations in the overlying epidermis to create epidermal ridges. Epidermal ridges are raised portions of the epidermis that are usually thicker and more complex than normal skin. Collectively, epidermal ridges are called friction ridges. Friction ridges, or friction ridge skin, is found on the palm of the hands and fingers, as well as on the soles of the feet and the toes. This skin is different from other skin because of its raised ridges, thicker epidermis, and the absence of hair and oil glands. This skin, these friction ridges, increase our gripping ability in our hands and feet. If you look at the palm of your hands, you will see that the surface is lined. It has small lines in it. The friction ridges are located between those lines. And again, those ridges help you pick up a glass of water or a pencil. Friction ridges on the tips of your fingers make fingerprints. Sweat pores that open along these ridges secrete sweat and allow us to leave a thin film or fingerprint on items that we've touched with our fingers. As you can see from the picture over here, the friction ridges on our fingers make three main types of structures: the loop, the arch, and the whorl. The combination and appearance of these structures is genetically determined and unique to each individual human being. Even identical twins, two people who share the exact same DNA, do not share the same fingerprint. Deep to the papillary layer of the dermis lies the reticular layer. The reticular layer makes up about 80% of the thickness of the dermis, and it separates the epidermis from the hypodermis. The reticular layer is composed mostly of dense, irregular connective tissue. There, the collagen fibers provide strength and resiliency to this layer of the skin. Elastic fibers provide stretch and recoil properties. The reticular layer is rich in proteoglycans that draw water into the ground substance of this layer. This helps keep the skin firm, plump, and hydrated. Lamellated or Pacinian corpuscles in this layer, which you can see in this image right here. They're found embedded within the reticular layer. These are sensory receptors that respond mainly to changes in pressure and vibration that are associated with the skin. You'll also find blood vessels, sweat glands, hairs, and sebaceous glands, along with a bit of adipose tissue in this layer of the skin. The reticular layer is made up of dense, irregular connective tissue. You'll remember from Chapter 4 that a major feature of this tissue is collagen bundles that run in various planes, which allow the tissue to be stretched in many different directions. At the skin, most collagen bundles run parallel. Gaps between the bundles cause indentations in the epidermis called cleavage lines or tension lines. Surgeons plan incisions to align with tension lines. This minimizes tension across the incision as the wound heals. These types of incisions heal faster and with less scarring. When tension lines are parallel to an incision, the incision heals more slowly and tends to scar. Skin wrinkles are a hallmark of aging. They are due to age-related decreases in collagen fibers, elastic fibers, proteoglycans, and adipose tissue in the dermis. These changes reduce the skin's firmness, hydration, and recoilability after stretching. And wrinkles tend to be deeper in areas of repetitive muscle movement like the forehead and around the eyes or mouth. UV exposure and cigarette smoking seems to accelerate the formation of wrinkles. Outside of surgical interventions, there is no real cure for skin wrinkles. Their appearance can be minimized, however, by treatments like Botox. This is a preparation of a bacterial toxin that is injected into the skin, and it paralyzes the facial muscles underneath. While this treatment smooths the skin, it can also impair a person's ability to use their face to convey emotion. The results of Botox last typically 3 to 6 months. Alternatively, you have fillers. Fillers are things like adipose tissue, collagen, and or proteoglycans that are injected directly into wrinkles. They plump the skin up and make it look more firm and youthful rather. Fillers last anywhere from about 6 months to a year. Then you have topical creams, especially your non-prescription types. These claim to reduce the appearance of wrinkles, but usually have very little to no effect. The best way to treat skin wrinkles is to not get them in the first place. Avoidance of the sun, the use of sunscreens, maintenance of proper hydration, that means drinking plenty of water, and avoiding smoking can delay the appearance of wrinkles. So now let's take a quick break and see what you remember. The principal tissue found in the reticular layer is that dense irregular connective tissue, stratified squamous epithelium, dense regular connective tissue, or areolar connective tissue? Pause the video and join me when you have your answer. Dense irregular connective tissue is the right answer here, and I knew you would get that right. Here's another one. Fingerprints are copies of, would that be dermal papillae, epidermal papillae, dermal ridges, or friction ridges? Friction ridges, good job. The last topic for this video is skin color. There are 3 primary pigments that add color to skin. The first is melanin, which we looked at earlier in this video. Remember, it's kind of a brownish orange pigment, and it gives a brownish orange hue to the skin. Melanin is absorbed by keratinocytes, and it forms a pigment shield, which you can see here, over the nuclei of the keratinocytes in the stratum basale. This protects the DNA in those nuclei from damage by UV light. Freckles, brown birthmarks, and pigmented moles are all examples of local accumulations of melanin. Carotene is a yellowish-orange pigment found in certain foods like oranges, sweet potatoes, carrots, and cantaloupes. When people eat large amounts of these foods, carotene can accumulate in the skin. This is most noticeable in the palms of the hands and the soles of the feet. So if you compare this hand to this one over here, you can see that there's definitely a yellowish tinge to the skin. Hemoglobin is the protein in red blood cells that makes them red and helps them transport oxygen throughout the body. Hemoglobin in blood vessels close to the skin gives the skin a pinkish hue, like this that you see in this image of Ed Doring. Color changes associated with the amount of blood flow in the dermis can be useful in the diagnosis of disease. Erythema, or flushing, occurs when blood flow to the dermis increases and the skin takes on a reddish hue as a result. You can see an example of erythema here in this young child's cheeks. You see this pinkish hue that almost borders on red. This is a normal response during exercise because blood flow to the dermis increases to maximize heat release from the blood. But erythema can also occur when blood flow increases due to trauma, fever, inflammation, or infection. Pallor occurs when there is reduced blood flow to the dermis and it results in a loss of the normal hue to the skin. This is most noticeable in pale-skinned individuals. The epidermis may take on a whitish color from the collagen fibers in the dermis. Pallor may be observed normally when the body is trying to conserve heat in a very cold environment, or when the nervous and endocrine systems adjust blood flow as part of our fight or flight response. It can also be a symptom of anemia, hypovolemic shock, that's a condition where the amount of blood plasma is extremely low, and it can be a symptom of extreme hypothyroidism. Cyanosis, like you see at the fingertips here, is a sign that someone is having a medical emergency. This is a bluing of the skin and mucous membranes and occurs when hemoglobin has low levels of bound oxygen. As a result, the blood takes on a reddish purple hue. For people with brown skin, it may be necessary to look at the mucous membranes or the skin around the nails to detect this condition. Cyanosis can occur when someone has difficulty breathing or a severe reduction in hemoglobin levels or red blood cells. Some types of poisons make it impossible for hemoglobin to bind oxygen, also leading to cyanosis. Now let's do a few review questions and we'll wrap this video up. The touch sensors of the epidermis are would that be keratinocytes, tactile cells, epidermal dendritic cells, or melanocytes? The correct answer here would be the tactile cells. Remember, these are also sometimes called the Merkel cells. Great job. Let's try another. The principal role of melanin is to give one that healthy tan look, keep the body cool, provide a waterproof layer, or shield the nucleus from damage by UV radiation. Of course, shield the nucleus from damage by UV radiation. Remember, melanin accumulates around the nucleus of keratinocytes in the stratum basale. There, it prevents UV radiation from damaging the DNA inside the nucleus. The wrong damage to that DNA inside that nucleus can result in disorders like skin cancer. Which of the following skin colors may indicate anemia? Would that be erythema, bronzing, black and blue marks, or pallor? That's right. Pallor is the correct answer here. Which three pigments contribute to skin color? Would that be keratin, melanin, and hemoglobin? Or keratin, melanin, hemoglobin? Or melanin and keratin only? Or hemoglobin, keratin, and keratin? I know that was tricky, but I hope you said keratin, melanin, and hemoglobin. If you said that, you were correct. So that brings us to the end of this video. We started out the video by talking about the types of cells that you find in the epidermis. This is often a multiple choice style question on the exam, so you'll probably want to remember that information. Then we talked about the layers of the epidermis. Remember, from deep to superficial, they were the stratum basale, the stratum spinosum, the stratum granulosum, the stratum lucidum, and the stratum corneum. We talked about all of the characteristics of those layers as well. I will not be looking for you to remember necessarily all of the details, but I will expect you to remember the names of the layers in order, as well as the important things like where keratinization happens, where the keratinocytes come from, what the keratinocytes look like by the time they get to the stratum corneum. I also described the layers of the dermis. We talked about the papillary layer and the dermal papillae. We talked about how dermal papillae form epidermal ridges and how epidermal ridges are a type of friction ridge and that friction ridges help you to grip things. We said that because there are sweat glands along the friction ridges in your fingertips, when you touch different surfaces, you leave behind a fingerprint. We also talked a little bit about cleavage lines. Remember, these are the lines that are in the skin that kind of show where the collagen bundles run parallel to the skin. They are the lines along which doctors try to make incisions so that the incisions heal properly. We also talked a little bit about factors that contribute to skin color and how changes in skin color may be clinical signs of disease, especially in the case of erythema, pallor, and cyanosis. I hope this video was helpful to your understanding of Chapter 5. In the next video, we'll talk about some of the accessory structures of the skin. I look forward to seeing you there.